But I'm going to focus more on what you might be more interested in terms of how do we get rid of this problem? How do we cure it? How do we get this better? So this is what we see on the scans, as you know, and what we end up seeing is calcium all over the brain in a way. So I want to point out, I mean, I'm hoping my pointer is visible to you as well. So this is the base of the brain where you see a lot of calcium deposition. Um, it's in the center of the slide if you're not able to see my pointer, but I think you should be able to. And then you see the bone, that is the skull, that is surrounding like a circle around it, the white circle that you see on this image. So what you can possibly guess is that in a CT scan, when you look at calcium, it looks very much like the bone, the skull, like the skull practically. So the same consistency, so same white. Um, and then, of course, there's gray brain, and the black is the fluid, and the darker black is the air that you can see here. So what we know is that calcium in the brain can be very easily seen on CT scans, but it might not be that straightforward on the MRI. So one of the things that we are learning more and more is a lot of people who are getting MRIs these days very frequently might be missed. So obviously, when we talk about treatment, the rational or a lay perspective would be calcium in the brain. Let's get rid of the calcium. That should be the treatment of it, isn't it? So that's how it should work. So it's not completely incorrect, and I'll tell you a bit more about it. So we got all these genes that have been described that cause what we now label, as Adam mentioned, primary familial brain calcification or idiopathic basal ganglia calcification. Now, these are two terminologies that are quite complicated for a layperson, but I'll just explain them a bit because it's important. When we talk about treatment, especially, the label is important because we often talk about something called a Fahr syndrome, which is something, let's say you went for a scan and a radiologist said, these features are consistent with Fahr's, and then you don't know whether you're talking about a disease or you're talking about a syndrome. But obviously, when you have calcium in the brain, it could mean many things. And what we are focused on as a charity as well from Far Beyond, as a research group that we work in Queen Square, we are more focused on the primary familial brain calcification, which is a condition where there is no secondary cause of calcium in the brain, because the scan that I showed you, you could get calcium in the brain due to many other reasons as well. But we are focused mainly on the people who have no previous injury to the brain, no hemorrhage in the brain, no infection to the brain, but they still get calcium in the brain. So that condition is called primary, meaning no secondary cause found. Familial, sometimes, or more likely, they're familial. Brain calcification or basal ganglia calcification. So basal ganglia is the name of the part of the brain that I highlighted in this scan, for example. That's the part of basal ganglia. That's why this is important to highlight. Now, of all the things that cause calcium in the brain, the genes have been discovered in the last almost 10 years now. There's like a spurge of them. Most of them were thought to be familial, and the top 4 on this table are autosomal dominant. So autosomal dominant, which is inherited as AD, as it's mentioned on this slide, would mean that if you have a bad gene, there is a 50% chance or more or less, depending on the penetrance, of passing it on to a child. So even if the child inherits one bad gene from one parent, they will manifest the disease. And that's what we knew about the genes that cause PFBC till recently. And then there are new genes that have been mentioned as the 3 bottom ones, where I have highlighted AR, which means autosomal recessive, in which case there may be a family history in a cousin, maybe a family history in a distant family member, but not in the parents necessarily, because you need 2 bad genes to come together to cause the same condition, which is the primary familial brain calcification. Now, my importance of mentioning this is because this also changes a bit of approach in why we call it familial or not call it familial. Whatever we call it, I think we've been arguing about this for many years, but Fahr's is a commonly recognized name, so I'm going to not ignore that and stick with that description as well. But I do want to highlight, as I just mentioned, treating Fahr's does not always mean treating the idiopathic form of it or the primary form of it. Sometimes there are these secondary causes. So I don't want to bore you with all the medical literature, and I know I have limited time, but these are the kinds of things that people can have, which will lead to brain calcification in the end. So what you'll see on the scans would be slightly different to what I've just shown you, but it would have calcium on the brain that will look exactly white like the bone, as I showed you in the thing. So sometimes people can have some vascular abnormalities, some age-related developmental changes, metabolic problems. Particularly, we're interested in the parathyroid, because some people can get parathyroid problems, which lead to calcification in the brain. Very commonly, especially in the tropical areas, infections are a very common cause of calcification in the brain, some autoimmune conditions and toxicity as well. So I think one of the first things we do in a clinic when you see someone with brain calcification is to make sure that they haven't got any of these. And then we are talking about the treatment options for what we call PFBC. We have done sort of an analysis of what patients present with and what would symptomatic treatment entail. Broadly, the symptoms are divided into neurological, psychiatric, cognitive, headache, etc. But I mean, we work in the movement disorder center, so I'll be very focused on the movement disorder side of it. But I know that that's not the only presentation. There's lots of people who present with seizures, lots of people present with memory problems, cognitive problems, many with headaches, speech problems, gait problems that are very non-specific as well. And a lot of patients who have so-called the genetic cause and they have PFBC do not have any symptoms at all. And I think it's very important to understand that, because then they don't need treatment. But coming to treatment, I think very important to understand what is actually going wrong. Why do they get calcium in the brain? Why do people with brain calcification actually get the problem? I don't want to bore you again with a lot of biology, because I have I'm aware that people who are attending this webinar will have very different understanding of neurology or science in general. Just to give you a broad perspective, let's say there is blood vessels in the brain, and whatever we call it a blood-brain barrier, is a barrier between the blood and the nervous tissue, which prevents all toxins and all the chemical things that are present in the blood to just pass through to the brain, because brain cells are very sensitive to changes. So it is in a way protected from the whole environment of the body through this blood-brain barrier. And that requires a very important tight junctions between the blood cells. It also requires some very interesting cells around the blood vessels, the pericytes, and they also have some small muscle cells around the blood vessels that help them shrink or open depending on how much blood needs to flow through the brain. Now, what we know about brain calcification is a lot of the problems that happen are in this area, particularly in the cells that surround the blood vessels, and they separate it from the brain tissue. And I'll tell you a bit more about it. So all the genes that we have, a lot of them have problems in this area, and that's the reason why the calcium would deposit. The other key aspect of the whole of this is a compound called inorganic phosphate, or PI as it's labeled here. And there's a transporter of PI, which is inorganic phosphate transporter, which is very crucial. And you can imagine that when we talk about bone, and I just mentioned the calcium looks very much like the bone, there is a combination of calcium and phosphate that create the bone. And calcium and phosphate metabolisms are very closely linked together. So interestingly, it's the phosphate transporters that are very, very important in this condition. So things we know that go wrong in PFBC is that there's an inorganic phosphate imbalance. So the transporter 2, which is the phosphate, inorganic phosphate transporter 2 called PIT2, is important. And when this is faulty, let's say due to a genetic mutation, there is increased concentration in the fluid that surrounds the brain with phosphate. So there's more phosphate in many of these, and I'll tell you a bit more about this, but this is one of the problems that happens is there's too much phosphate in the extracellular around the brain tissue, and there's so much increased phosphate in the CSF as well, in the fluid that surrounds the brain. And this might induce some of the vascular smooth muscle cells, which is the blood vessel cells that I mentioned, to become bone-like. And then they start creating the mineralization process. The neurovascular unit is what I showed you in the previous slide as well, is the kind of unit that comprises of the whole unit of nerve cells and vascular, including the cells that are important for immunity perspective and glial cells. So all of the mechanisms that we know lead to these two broad areas. So what people have suggested, and this is a review from last a couple of years ago now, 2023, is that if you have any of these mutations, somehow they link to the bone-like formation in the brain, which is mediated by phosphate and impaired vascular flow. So in terms of the treatment options, coming back to the main topic, the idea would be to take the calcium away, which is a very logical, straightforward idea. The second idea would be from a rational perspective, if there's a problem with the gene that's leading to this, why not treat the gene? Why not solve that? The third approach that can be thought of is that if there's too much of a phosphate buildup in the CSF and the tissues around the brain, why not just take the phosphate out? And that might improve the treatment, that might improve the outcome. And the other way would be to look at there's a problem with the neurovascular unit, so why not focus the treatments on the neurovascular unit? So this is not science fiction anymore. So there are people out there much more clever than me who've already done a lot of these things. So one of the first reports that came in 2016, in fact, was somebody tried a drug called alendronate, which is a biphosphonate, which is used in bone metabolism to improve bone health. And 7 patients treated with this showed stable progression over the years, although there was no improvement. There was only mild symptomatic improvement in some cases. But this was encouraging because the most important bit is that alendronate is a common drug that is used all over the world for bone health, improving bone health, and no side effects were reported in patients with this condition. So that encourages the idea that there may be more things, and Dinek is on the call, so I'm not going to bore you more with this study that she set up, which is amazing. It uses another similar drug called etidronate. The other approaches that have been tried is, of course, the genetic approach. Now, again, I know most of the people attending would not know everything about the genetics, so I'll just give you a very simple perspective of what can be done. So there's DNA, where there is sort of where the genetic coding is present. What happens from the DNA is there's generally a protein that is synthesized through the RNA, and this process is sometimes called transcription from DNA to RNA, and then RNA to protein is called translation. So this is the general idea of how the body works, and everything in the body that we have is a sort of like a genetic code translating into a protein. And that's how most of the diseases are approached. So what can be done in people who have gene problems is that they can, while this process is happening, we can stop the wrong translation by doing something called sort of interfering with something called RNA splicing, where 2 signals come together and they exclude the part that is not coding a signal. And the approach we use to do that is something called antisense oligonucleotides, so in short, ASOs. Now, ASOs have been used in many disease conditions, and just coming back to what I said, so if you just look at the center of this page, you'll see the DNA being converted into the RNA and then being to the protein. Now, ASOs can do 2 things. Either they can be attached to the RNA and alter the protein that is being created, or if there is a faulty protein being created, they can actually bind the mRNA and avoid the protein synthesis. So if we feel that in a disease, there's too much protein being secreted, we can do the second part, where is stop the protein synthesis, or if we think the wrong protein is being found and we have a way to correct it, we can alter the protein product. So there's now this approach, and SLC28-2 is one of the commonest genes that is known to cause brain calcification. And some brilliant colleagues in China have come up with this idea of developing an ASO to prevent the wrong signaling from SLC28-2 gene mutation. So let's say if somebody's got a faulty copy, which you can see possibly on the orange side of this slide. So the normal would be 2 similar kind of genes that produce normal protein, and whatever is not normal is degraded. Whereas if one copy is faulty, which is the gene that is faulty, the autosomal dominant gene, so even one gene being faulty causes this problem, what they can do is they can put the ASO in between to improve the production of SLC28-2 as a normal protein. And that would mean they've also shown it with the animal model that it actually increases, so it reduces the phosphate collection in the brain with the correction. So the second approach I mentioned was targeting the inorganic phosphates. Some people have recommended that this is a great way to monitor response to treatment, and this can be used as a biomarker, etc. But that comes with the caveat that some other studies, like the first one on the top, said this is perfect. In all their patients, they had increased level of phosphate transporter, sorry, increased level of inorganic phosphate in the CSF. But the second study that I've cited here did not find that, and 3 of their patients that were studied did not have increased CSF. And now we are learning that the level of phosphate increase in the CSF is not necessary, as necessary as was initially thought. But nonetheless, I mean, there is problem with phosphate accumulation either in the CSF or in the extracellular brain tissue. Can we reduce the phosphate can we do that in some way to reduce that level is an interesting question to answer yet. People have also started looking at what goes wrong in the cells specifically. So in the neurons, people have actually, there's another gene called myog, which is known to be associated with a reduced reduction of the activity of alpha galactosidase. So there are lots of things that are happening in this field in terms of finding out the ways to target the genes that are faulty, either working with gene therapy or changing the protein alteration or changing the effects, that is the phosphate accumulation, and also in the downstream correcting the calcium. We are also working on quite a lot of research at Queen's Square. So we've got a prospective cohort, we've got a retrospective cohort, we have a biobank, I'll tell you more about it. And then we're having collaborations on molecular research. One of the things that we realized as a, let's say, a fraternity very dedicated to brain calcification is that there's still no consensus amongst the scientists even on the terminologies used, on the ways used and the tools used to assess these sort of situations where how do we monitor response to treatment, etc. So we are working on these two projects, consensus and a tool to sort of be able to monitor brain calcification clinically as well as for research. This is a rare movement disorder and Fahr service that we have at Queen's Square. We've set up a new rare movement disorder service, and we are really building it up with a lot of our colleagues. And the key person who's not here today, should have been, but she's busy with something else, is Francesca Megrinelli, because she's doing quite a lot of work with this brain bank. So she's already collected quite a lot of samples, because to solve the problem, the best way is to go to the cells and understand each and every pathomechanisms. This is what we know so far, but does not mean this is all we'll ever know. So I think it's very important to move forward in this area. And she's collecting, so it just requires 15 minutes, collecting a serum sample or blood sample or skin sample, and that should be done. And then we've got this lab, and she's really good at finding answers for us in a way. And